Seja bem-vindo ao Podcast MGFamiliar. Um podcast sobre temas pertinentes que nos fazem refletir e frequentemente com implicações para a prática clínica. E damos as boas-vindas ao nosso anfitrião, professor Carlos Martins.
We are recording this special episode in the Preventing Overdiagnosis conference. Dear colleagues, we are talking from Oxford, and with me I have a special guest, Mina Johansson. In previous episodes, we have already focused some of her manuscripts, her studies, her publications, and it's an honor to have you with us in our podcast. Welcome, Nina.
Thank you. It's so nice to be here, and I'm so honored that you have talked about my papers and stuff. That's really a compliment. So thank you so much for having me here.
Thank you. One of your main field of work is related with the problem of the current expansion of preventive medicine, and I believe you are worried that it may harm the work of family doctors and the tasks of primary healthcare doctors. Can you share some thoughts about that?
Yes. So, preventive medicine has expanded almost exponentially during the last decades. It's through lowered cutoffs for risk factors, and it's through expansion to new medical territory, for example, that we should try to change our patients' lifestyle on a great scale. And this has many benefits, of course, but it also has potential harms. And I think one of the biggest problems is that it has expanded so much that it's now labeling the majority of the population as in need of medical attention to reduce their risk of cardiovascular disease or osteoporosis and a lot of other diseases. And so we have basically gone from targeting high-risk individuals within clinical practice with preventive medicine to targeting a great proportion of the population, low-risk population. And the consequence of this is that it takes a lot of time for us GPs to do it. And there are many studies showing this problem. For example, there is a Norwegian study showing that 80% of the population, according to guidelines, need to see their GP to reduce their cardiovascular risk. And it would take more time, more GPs than are available in Norway to only follow the guidelines on hypertension. There's one study from the US showing that it would take 14 hours per day for GPs to follow the guidelines on preventive care, and another one from the UK showing that it would take more doctors of all specialities and 5 times as many nurses as working in the NHS to follow the guidelines on lifestyle interventions. So if we would follow the guidelines on preventive medicine, we would have to stop all other care. We could not see any patients with suicidal thoughts or investigations for symptoms of cancer or, do anything else. And that's, of course, very problematic. We
wouldn't have time for patients with acute disease.
Exactly. No, suturing of wounds or or anything. Or pneumonia.
Yes.
And so this expansion of preventive medicine has made healthcare inefficient because we don't spend our time on the interventions with the greatest benefit or strongest scientific support. Also, it has made it unequal because we don't spend our time with the patients with the greatest care needs, which are arguably the patients with symptoms. And it also adds a lot of stress and ethical stress for us as GPs.
Okay. This is a quite different mindset and a different view of what we see in the real world still today. How can we move from the real world, the reality that we have, the pressure that we have from our colleagues, even from other specialties, for example, when we think about cardiovascular guidelines and so on, to a new reality that would be more compatible with your thoughts?
So I think no one wants inefficient and unequal care. I think this is mainly a problem of communication. So if it was up to me to decide, which it should be, right?
Yes, true.
Then I would say that I think that primary care physicians should prioritize our time for the people who are sick and try to prevent disease for people with the highest risk to develop disease. And I think this could be done. We need to find ways to communicate to policymakers and those writing the guidelines and to the public we need to find ways to communicate the consequences of recommending much more preventive care than we have time to implement. And the consequences of that, it's not only that, that we will work overtime and that we don't have time to drink coffee and or dance or whatever. It's also that it causes a lot of suffering because people who need our care won't get it. And that's what we need to find ways to communicate, I think, because no one wants this. No one would want all GPs to stop all other care and only give hypertension care. No sane person would actually want that to happen. So it's kind of a misunderstanding.
Yes.
What do you think?
I agree. Yes, I think I agree with you. And this brings us to the workshop that you presented during this conference here in Oxford. And you are trying to develop a new kind of systematic review that would help the decision-making or the policies making. Can you share a little bit about that?
Yes. So it's a concept that we call vertical reviews. It's a working name. It might change. But the idea is that, if we want to reduce cardiovascular disease risk in 80% of the population, then it's quite questionable to think that target one individual at the time within healthcare is the best and most feasible, most effective and most feasible approach. So we're thinking that we could do like a new concept or a new framework to compare different strategies to prevent disease in the population. So, for example, if you want to reduce cardiovascular disease risk in the population, you could either treat people with hypertension, one individual at a time within healthcare, or you could legislate on salt intake in fast food, for example, or have higher taxes on tobacco, which makes people smoke less. And then we want to basically do an evidence review where the benefits, the harms, the costs, and the burdens are compared across these interventions, across these different levels. So basically, the idea is to make, for the people who decide where to put the effort, where to spend the money or the resources, to give them the evidence to make the trade-offs between the benefit of different approaches versus the burdens to both individuals, professionals, and the systems, to make them explicit and clear so they can make better informed decisions.
Okay, so just to clarify, you would have at least 3 levels of evidence. The evidence about interventions related to the structural, to the entire country, for example.
Yeah, targeting the population, the whole population. Yeah.
And then the community level, that would be interventions more local.
Yeah, targeting groups or
group of patients or
communities,
small
like smaller
towns,
communities, local context. Yes. Yeah.
And then the individual level that relates to the encounter between the family doctor and the patient.
Exactly. Yeah.
Okay. I believe it's a very good idea, this new kind of review. Vertical, as you call it. Yeah. You could also call it holistic review.
I think you're right. I agree. That's a better name. Maybe I will steal it from you.
Okay.
And can I add one thing? I think the important thing that in the analysis that are done today, we don't appreciate the burden. So, for example, the burden in terms of clinician time, it's not estimated. It's not understood. So we look at the benefits, the harms, and the costs, but we don't understand the burden and the sustainability. Like how will this intervention or this strategy to improve public health affect sustainability of the healthcare system or of our communities, our economies, or our societies? And I think that's what we want to add with the vertical reviews also. So to compare different levels, but also make the trade-offs between benefits and burden really explicit.
I understand. And how does this all related with overdiagnosis prevention?
Yeah, I think it is because, what's happening with the expansion of preventive medicine is that we are labeling a great majority of patients as having increased risk, having hypertension, having hyperlipidemia, having osteopenia, having prediabetes, etc. And that is a kind of overdiagnosis. Yes. So instead of looking at the structures that could actually change these risk factors across the whole population, we target one individual at a time, we label them with a risk factor, we tell them that they have an increased risk, and we try to change that risk one individual at a time. And that is like an ineffective and strategy, I would say.
Mina, thank you very much. It was great to have this talk with you, and congratulations for all your work.
Oh, thank you so much. It was very nice to be here. Thank you.
Dear colleagues, this was a special episode of our podcast. See you next time. Until then.
Terminamos assim esta edição do Podcast MGFamiliar. Muito obrigada por nos ouvir. Se desejar completar a sua leitura, muitos dos conteúdos abordados neste podcast estão disponíveis em www.mgfamiliar.net. Até ao próximo episódio.